All right. Well, as I see folks coming in, I'm going to jump in. I know we have quite a bit today we're really excited to get to, and about 30 minutes to do it in. So welcome, everyone. Thanks for joining us today in the lead up to Women's Health Month for our webinar, Talking All Things Women's Heart Health. I'm still recovering from our big event last week. As you can tell, my brain is maybe not functioning as well as it should be. My name is Katie Schubert, and I'm president and CEO of the Society for Women's Health Research, or SWHR. And for those of you who may be new to us, SWHR is a more than 30-year-old national nonprofit dedicated to advancing women's health through science, policy, and education while promoting sex differences to optimize women's health. And like I said, we are really excited for today's fireside chat conversation to provide an overview about the current state of heart disease screening and diagnostics, what barriers may hinder women's access to care, and what women should be doing at each age when it comes to managing their heart health, which is a big topic these days. And so I'd like to start by thanking the sponsor of our heart health policy program, Amgen, whose support has made this event possible, and note that SWHR maintains editorial control over program content. And before we get into today's conversation, let me just run through a few very brief housekeeping notes. Note that we are recording this web event and we will post it online. We'll share the link once we have it ready to go, and any resources mentioned in the follow-up email to our registrants.
You can hear.
Time permitting, no worries. We'll ask questions at the end of today's event. I would ask you all to use the Q&A function, and we'll be monitoring that. You could use the chat function, but if we could all keep it in the Q&As, that would be wonderful. And then if you need any technical assistance, you can put that in the chat function. We are looking at it, but it may be a little bit delayed just given that we are running the webinar at the time. And then you can see the note here. There's a live transcription feature if you just click CC Live. So with that, I am going to introduce Dr. Stephanie Coulter from the Texas Heart Institute. We are super excited to have you here, Dr. Coulter. And I'd like you to just maybe tell us a little bit about yourself and your path to heart health.
Well, excellent. I am a non-invasive cardiologist practicing here in Texas, and as the director of the Women's Center and one of very few, I'm in the minority here, female representatives on the cardiovascular service line. I've been involved in women's health and in women's focused research for the last really 20 years. So I have a breadth of experience because I'm a practicing cardiologist, and I am a director of non-invasive services in cardiovascular care at the hospital and in the office. And so I use all the techniques I have to examine, general cardiovascular problems, and I'm interested in non-atherosclerotic cardiovascular disease, which is particularly common in women, or it's rare overall, but it's more common in women. So.
Excellent. Well, thank you for that. And as you noted, and it's something that comes up quite often, not only is heart disease something that presents differently for women, so we have these sex differences, but you also note sort of the proportion of female cardiologists, which I feel like we could be doing better on. So thank you for all of the work that you're doing to represent in the field. And maybe we'll start knowing that cardiovascular disease is still the #1 killer of women. And we've heard stories from all over the country where, a woman might present at an emergency department in an active heart attack and not be diagnosed and not seen appropriately. So maybe I'll start with sort of backing up that process. What diagnostic and screening tests currently exist for diagnosing cardiovascular disease?
Okay, so it's been a revolution in the last few years because in the olden days, and I'm old enough to have worked during the olden days, which is actually really great because I have a very good perspective on what we used to do and what's current and useful. So the most important thing for any woman listening to this webinar is to know what risk group they're in, okay? Because everything we do is viewed under the glass, the magnifying glass of what's your risk. So if you walk into the emergency room and you're in a very low risk group, you may get ignored, okay? Because the doctor seeing you is going to be biased against having heart disease in somebody in a very low risk category. And the low risk category is predicated mostly by age. So if you're a young premenopausal woman with chest pain or shortness of breath, then the physician seeing you is going to be more concerned with pulmonary embolism or other non-cardiovascular events. The most important thing is that if anyone shows up in an acute care facility with chest pain or shortness of breath, the single best screening test, besides listening to the patient and having a high index of suspicion, is really the EKG. So an EKG, of course, is 1914 technology. Okay, so it's not that sophisticated, but it's readily available. And every doctor is trained in the basics of reading EKG. So it's a wonderful screening tool in an emergency room setting. And the most important thing I can say is that if you're in a low risk group, demand that you get an EKG, because there are these very rare causes for heart attacks that young women get. And I probably see 2 or 3 of those women in follow-up a week. So I'm always thinking, the doctors in the ER for these women where they were adequately and properly diagnosed, they didn't ignore them. They didn't ignore their symptoms, and they looked at the EKG, because the EKG, when you're having a heart attack, it's not perfect, but it's really good. So the first thing is the EKG. The first thing is really the index of suspicion, the clinical risk group. Then there's the EKG. Then for acute symptoms, then we use the CAT scan so much now. CAT scans are the workhorse engines in the emergency departments of real emergency rooms. But if you go to a doc in the box place, like many times they don't have access to a CAT scan. And people like to go to these low risk kind of clinics. But if you're having bad symptoms, you really need to go to some really more, technologically sophisticated environment. Because if you show up in the doc in the box, they're going to put you in an ambulance, and that's going to cost more money. So one, seek out medical care in a better, higher level of service. Like it has to say emergency room in order to get a CAT scan, because they're going to have a CAT scan there. The CAT scans are very important because they can look at pneumonia, they can look at your aorta, they can look at your pulmonary vasculature to see if you've had a pulmonary embolism, and they can look at your coronary arteries. Okay. Now, many emergency rooms don't have the sophisticated imaging techniques to look at the coronary arteries, but in really major centers, and the way that we're now assessing chest pain, acute chest pain, the CT scan has moved up big time on the list of procedures. Okay. Another test that may actually be quite helpful if you're having chest discomfort is an echocardiogram. Now, I'm actually an echocardiographer, and we have technology that is portable, it's real time. In emergency rooms, many emergency room doctors have small, focused echocardiogram, imaging techniques. So it's moved from, this, tower of ivory into the emergency room and into the hands of the physicians that are actually caring for the patient. So if you're having active chest discomfort or shortness of breath, an echocardiogram is actually a really excellent test, because it can show, so much pathology. It can show whether or not you have wall motion abnormalities, dysfunction of the left or the right ventricle. It can tell you what the pulmonary artery pressures are. It can tell if there's a fluid collection around the heart. So, it's an excellent test. And that's the reason why it's become part of an emergency physician's repertoire of techniques that he can use. Last case scenario, I guess, is if we're not sure or if we have other reasons to suspect coronary artery disease, which is the lion's share of heart disease still. And it is the #1 killer of women, even in women that have had cancer, particularly breast cancer. The number one cause of death in breast cancer is really heart disease. So the coronary angiogram is used in patients who are suspected of having severe coronary artery disease that's affecting, breathing or cardiac function. And an angiogram can be used in an emergency situation to diagnose and to treat a critical blockage in the heart. So those are the main kind of tests that we use in an emergency setting. But in a long-term chronic setting, looking for people that are at risk, which is very important now. And I'm going to say this is a big statement. In the olden days, we thought artery disease was inevitable, okay? That everyone basically got artery disease. And so we used these stress tests where you get on the treadmill or you lay and you get a chemical infusion, and we looked for evidence of ischemia or amount of blood flow that was being reduced in the heart of a patient with a critical or at least a 50% blockage, okay? Because it takes about a 50% blockage in a major artery to cause symptoms. So the stress test is wonderful. I love it when you're evaluating chronic symptoms, okay? But if patients are just coming to see you for an evaluation of, do I have risk for heart disease in my lifetime or in the next 10 years? The stress test is often normal because they don't have a 50% or greater blockage. So we're using the calcium score test or the heart scan big time now to see how much plaque people are laying down before they have symptoms. Because if we catch them way before we have symptoms, we can prevent disease. So we've moved the needle from how much plaque do you have that's causing symptoms to, do you make plaque? And if you do, can we stop you from making it? And the answer is we can. So it's been a paradigm shift in how we take care of patients and how we prevent disease, because now we can customize the treatment to how much plaque you have, or if you're making plaque or if you're not making plaque. We will ease off on the preventative strategies, particularly with the treatment of the LDL cholesterol.
That's amazing. I mean, just in thinking about how far we've come, right? And, what we want to do really is prevent anyone from, even presenting in the emergency department with an active event, right? And so from your perspective, as you're thinking about this preventive screening process and also this risk assessment, when do you think women should be consulting with their healthcare providers about sort of what does their heart health look like and why they may or may not need to be concerned about it?
Okay, that is the greatest question. And I really appreciate you asking it because, in fact, it depends. So it depends on several factors. Number one, mostly your age and your menopausal status. So if you're premenopausal and you still have regular periods and you do not smoke and you do not have type 1 diabetes, you can wait probably until your age is about 50 to get a cardiovascular screening exam. But you really should see a primary care doctor in your 40s. And that could be a primary care doctor, could be your OBGYN, which, probably 40% of women in this age group really only see their OBGYNs. And they do a very nice assessment for cardiovascular risk with looking at blood pressure and looking at cholesterol levels, okay? So in this period, if you are starting to get hypertension, or if you've had pregnancy-induced hypertension in your past, or gestational diabetes, those are risk factors for, I'm at a little bit higher risk for heart disease, and I need to be screened for hypertension and for type 2 diabetes in my 40s, because the likelihood that you're going to go on to develop one of those two problems is higher than in the general population. At 50, women are going kind of close to menopause. So the average age for menopause now is between 51 and 53. And the risk factors for heart disease, they overlap with menopause. So menopause is really the biggest time period in a woman's life where her risk factors start to increase. And when the risk factors start to develop, then that's when you need to screen this woman and start treating these risk factors so you can prevent plaque from growing. At age 50, in a premenopausal woman, that likelihood of having significant plaque is very low. Okay, it's very low. Most women in this age group have 0 calcium scores, okay, which is a marker of long-term cardiovascular risk. But if a woman at 50 smokes or has type 1 or longer standing type 2 diabetes, she's at greater risk, and her calcium score may reveal that she's already laying down plaque. And how much plaque is related to that calcium score. And so the calcium score, the heart scan test, is extremely helpful because it's not just yes or no, because it is yes or no. Do you make plaque, or have you not started making plaque yet? Okay, at that age. And then if you make plaque, how much plaque have you laid down, and how much risk are you in? So we use that time period in a woman's life and her risk factors to customize the treatment for prevention.
I want to pull out a couple of things there that you
Please do.
Because one of the things that has been really important, particularly as we talk it, right, when we think about women of reproductive age and the maternal mortality rates and the risk associated with heart health and pregnancy, you highlighted something that I don't think gets enough attention, which is the risks associated for your health later on in life. So just want to make sure we are getting the word out again, right? Like if there's something happening during pregnancy, that stress test for your life, pregnancy is a window to future health. You really need to be aware of it. Unfortunately, there's not like an easy connection to be made. So I think that sort of falls to the woman themselves to be able to say, oh, I had preeclampsia when I was pregnant, and I know now that I need to make sure I'm being monitored. So I think that's one piece of this, is like that life transition, and then the menopause points that you said as well. My question for you, sort of beyond those couple of things, if someone thinks that they are at risk for developing heart disease, is there other information or things that they should be thinking about their health background or family history that they might need to share with their healthcare provider?
Okay, so I love all your questions, and I want to highlight one important part, because when people have pregnancy and then they raise their children, there's a big lag of 10 to 20 years before they develop, these earlier manifestations of early vascular risk. So people forget when they're pregnant that, oh my gosh, I did have pregnancy-induced hypertension. And I'm sitting in a room with another woman. I actually had pregnancy-induced hypertension. My colleague, Dr. Campos, and we are healthy people. You had it too. I mean, so it's not uncommon, but it is certainly a risk factor for later in life developing hypertension. So you have to be hyper astute about following, the things that cause hypertension. So what do you want to do? You want to live a healthy lifestyle, right? You don't want to have insulin resistance, because that raises the blood pressure as well. And how can you prevent insulin resistance, which is pre-diabetes or pre-diabetes? Well, you need to be active. You need to exercise. You need about 150 minutes of vigorous cardiovascular activity every week. That in and of itself in your 40s may actually stave off the development of hypertension until your mid or later 50s. I recommend, people knowing that they're at risk, that they watch their diet and make sure that it's not salt loaded and that they don't eat processed foods. So there are things that we as humans, as patients and collaborators can do to get the message out that, hypertension is not completely for sure in patients that have pregnancy-induced hypertension, but it's certainly very likely as you age. So knowing that you're at risk, and knowing, and that we're having these podcasts available to people to hear, puts an alarm bell in your psyche so that you'll know to be careful and to be mindful as you age.
Yeah, I think that's really important. And I appreciate you've talked a lot about sort of the tools that exist, what we need to do, where we need to go. I think given that, my question to you is, do you think that we have sort of this comprehensive assessment for women's heart health, or do you see that there are gaps that still exist?
Oh, there are huge gaps. There are gaps of awareness. There's gaps in medical education. So, you could be in my center and even all the men are really pretty good about women's health. I mean, there's a buzz around here about that. So in other places, there are definitely medical and awareness gaps in the community. I actually worked a health fair on Saturday, and the patient population was higher risk, but middle class families. And the epidemiology of hypertension in that cohort was enormous. And I kind of felt like there was this aura of permissive hypertension, like, oh, it's 140 over 90. I'm pretty good, right? And I'm like, no. The blood pressure goal is 120 over 80. It's been clearly shown that if you get the blood pressure 120 over 80 on average, you decrease the risk of strokes, heart failure, heart attacks, kidney failure, and cognitive impairment. So I was aghast and was doubling people's meds, making them make a diary. And these were patients that had access to medical care. Mm-hmm. So, having more self-awareness about the risks of hypertension in certain populations is certainly important, because African Americans get high blood pressure at a much earlier stage in life, which is probably one of the reasons why they're at double the risk for heart attack, stroke, and death.
Yeah, well, and actually you just jumped right into my next question, which is about the disparities that exist. And in women's health across the board, we see these disparities across, not just, for women versus men, but for different racial or minority groups. Like, they just exist in every condition that we look at. And there's a variety of reasons for this, and there's a lot of work that we need to do. But you just mentioned one disparity in heart health in particular, but I think that's another sort of question for you is, given these disparities, what do you think we could be doing and that women should be aware of, just in terms of those disparities, like this layering on of, the intersectionality of being a woman and being a woman of color, or being a woman in a rural area? Like, what are these issues that we need to be aware of?
Okay, number one, there are disparities in outcomes with acute medical care. Okay, so if I look, and I've done this, I've looked at the data from this big coronary hospital over a 30-year period, and we looked at the outcomes for women versus men, and women's outcomes are twice, negative outcomes are basically double the risk of men. But when we look at women and we look at men and we look at racial disparity, there's no treatment response differences amongst the races. So in fact, all women, including white, Hispanic, African American, they all respond to treatment equally, and the treatment is, non-biased. So that's very reassuring. Okay. So that means if there's excess risk in certain groups, it's not because of the way we treat them in the hospital once they get sick. Because once you get to a good center, the outcomes are the same, which means you've got to get into the community, because it's the prevalence of the risk factors and how those risk factors are being modified that I think contributes to that excess risk, which means as a community, and I mean a global community, we have to get to people at risk at an earlier age and address those risks, which is why I've moved part of my research efforts to going into the community, because that's where the risks lie.
Yeah, that's, I think, really part of this issue, right? Is how do we make sure we are meeting people where they are so
Yeah.
that we can raise that awareness, right? And I see exactly what you're saying, right? The outcomes, and I think you're right. It is heartening to hear that once you can get to where you need to get, that
Right.
treatments are
Well,
are but
I don't want to discourage people from seeking quaternary or tertiary care, because in fact, there's data that says that people that seek out that higher level of care, they do better. So
Mhm.
part of the risk for women is that they, in the past, and I will say that over my, I'm old, over my 30-year cardiovascular career, that women, the level of sophistication in medical care for acute cardiac events has moved into the community, and it's quite good. It's quite good. So just seeking care at a real hospital with real symptoms, you should get high quality care, even in community based, and even I think in rural locations. The problem is if you don't respond to treatment, and that happens in patients that get have cardiac events. Only 50% of people that have a heart attack and receive the clot busting drugs, only half of them will have reperfusion or establishment of good blood flow in their heart. Only half of the people do. So if you're in the group that fails, then you need to be moved quickly to a hospital that can handle that. And the window is really just, as quickly as possible. Which is, we live in Texas here. So Houston's a huge hospital, conglomerate of hospitals in the med center. And then we have the community, which is, probably 30 to 60 miles outside of the radius of Houston. It's still quite good, but it drops off rural, all around me. So we have patients that end up in those situations, and we're mitigating the risk with those doctors by ambulances, helicopters if they need to be. But we're not unique in Houston to other major medical centers. So the good news is that the most of the population lives really close to a really pretty good hospital, and the care in those hospitals has really improved dramatically. Most hospitals within this area have on-site acute protocols for heart attacks, where we go in and stent the patient or pull out the clot, address the proximal cause of the heart attack. And for stroke care as well. It's not as good in the community, but it's getting better.
Good. And I would note too that someone had put in the Q&A as well from the audience. And yes, I totally agree that the advanced tests that you had mentioned in the emergency setting are also available in a well-established cardiology practice. So that's always
for sure. And we do try to, discourage people with active, terrible chest pain from coming to the office, but they show up anyway. And, they're going to get the best level of care, and we're very close to the hospital. So we move people efficiently across the street on a bridge to get the care that they need. So you're right.
Yeah, no, all good. And I can see, we're out of time already. This has been wonderful. I know, I can't believe it. But I would ask you if you have any sort of final words you want to make sure our audience hears that either we didn't cover, or you want to make sure to really, press the point.
Okay. So the most important thing I can say is to be your healthcare advocate. Okay. Know what your risks are and get them treated. Okay. So this is my funny story, is that people are all into natural things, right? They want to do everything natural. Okay. And unfortunately, for some people, nature is working against you because you've got lethal genes, right? The LDL cholesterol in certain individuals is lethal. And you need to combat that lethal gene in addition to exercise and diet with medications. Okay. It's like we know the test answers and we know how to block it. Don't be afraid to take the medicines. The blood pressure medicines are great. The diabetes medicines are improving every year. We've got really great heart healthy diabetes medicines. There are there really kind of 4 classes of cholesterol medicines. Don't be afraid to seek preventative care after your healthy lifestyle has run its course. I mean, after you've done all you can do with that. So I see so many people that are, resistant to treatment, and that's becoming a problem for us to prevent disease.
Okay, excellent. Thank you for that. It also reminds me to share with our audience our campaign that we had called Read My Lips, Lipids, Know Your Numbers, make sure you know your risk. So I'll plug that as well. But also, thank you, Dr. Coulter. Thank you to our audience for joining us. I know that was fast and furious, but we encourage you to stay in touch with us, stay connected with us, sign up for our emails, our website, which looks a little bit refreshed now. So we're excited to share that as well, and follow us on our social media channels. But overall, thank you. And thank you, Dr. Coulter. I think the future is bright and we really appreciate your time.
My pleasure. You guys have a good week. Stay heart healthy.